Let everybody be born. I think last 1 minute. So let's get in our Zen, everyone. And just to tell everyone that these are not exam review slides. They're already in your renal folder. I will post these recap slides on Friday after I finish the last recap. And this, sorry, this file will be recap 1, 2, and 3 because I did the recap in 3 sessions, okay? It will be a separate file. So 1 more minute, get in your Zen. So we can quickly recap today, which is amino acid metabolism. Our last recap will be Friday. If I'm not wrong, the time is not determined yet, but it will be the last recap for renal, and then we'll do a combined review. Okay, so it's 6:05. Everybody can hear me? Everybody? Yes, you can see the slide? Right? Great. Today is amino acid metabolism. Let me get the pointer, my laser pointer, so you can clearly see. Again, I'm not teaching, bringing your focus. Great. If you are in your Zen, let's see what we can learn today. Today, we are only doing amino acid metabolism. I did talk about amino group disposal. I'm not going to address it today. When I come back after my last recap on Monday, we will do a combined review. Then I will bring back that. Yes, today we are going to talk about two things. One, carbon skeleton. Number two, amino acid and what are their products they form. And number three, inborn errors of metabolism. So you got to divide amino acid moving forward today into 3 sections. So let's do first the carbon skeleton. Please don't waste your time in memorizing reaction. What is this converging into? No. If it is mentioned that this carbon skeleton of alanine is converging into TCA cycle intermediate, it will give you energy. TCA cycle minus acetyl-CoA, glucose. Acetyl-CoA and derivatives, ketones. And pyruvate, glucose. So what are the amino acids that are ketogenic? Then you complete the list. So what are the amino acids that are purely ketogenic? It would be leucine and lysine. So don't flip-flop that. Very good. Leucine and lysine. I like that answer. So all you got to understand that if the amino acid carbon skeleton after amino group is removed, converges into in these TCA cycle intermediate, any one of them, it will give you energy. TCA cycle intermediate minus acetyl-CoA, glucose. Acetyl-CoA, ketone bodies. That's why the amino acid that converge into acetyl-CoA and derivatives are glucogenic or ketogenic. Those that converge into acetyl-CoA and derivatives, they are glucogenic or ketogenic? They're ketogenic. Then what converges into pyruvate? Anything amino acid converging into the pyruvate is glucogenic. So glucogenic, very good. So you're just knowing the fate. These last two reactions we have learned. We have learned alanine as a source of principal storage amino acid in skeletal muscle being glucogenic. We have also learned this pathway. So what is this full pathway of? Tell me. What was this pathway? Does anyone remember this pathway? What is this pathway? Fill in the blank. No, what's in here? Yeah, vomit converged into this pathway. Vomit were the intermediates, but this is propenyl-CoA, methyl-malonyl-CoA, succinyl-CoA pathway. I just wanted you to fill in the blank. So did we do this propenyl-CoA, methyl-malonyl-CoA, succinyl-CoA pathway? Absolutely do that. So here we are just identifying in carbon skeleton role, which is actually my lecture. We are only identifying glucogenic, ketogenic, essential, non-essential, conditionally essential. We also did an interactive session. What is conditionally essential? Vomit is valine, chain, methionine, isoleucine, threonine. This is vomit. It is given in my slides. All of them converge into propenyl-CoA, methyl-malonyl-CoA, succinyl-CoA pathway. I have mentioned that in the slide. I'll bring to your attention just now. That is vomit. Okay, I'll bring to your attention. Don't panic. Okay, relax. So now, first of all, for every pathway, if you want to get the enzyme deficiencies correct, write the normal. Phenylalanine tyrosine, normal enzyme, normal cofactor. Homocysteine methionine, normal enzyme, normal cofactor. Homocysteine cystathionine cysteine, normal enzyme, normal cofactor. Tyrosine, normal enzyme, there's no cofactor there. For example, tyrosine, who metabolizes homogentisic acid. For example, tyrosine, which enzyme metabolizes homogentisic acid? And is there any enzyme that metabolizes homogentisic acid or homogentisate? Anyone? PHA is phenylalanine hydroxylase. That's not for tyrosine. Also, this is a very good point. When you write phenylalanine tyrosine, please stop here. Tyrosine metabolism starts separate. Tyrosine forming its product, then tyrosine homogentisic acid. Remember fumaryl acetoacetate? So which enzyme was metabolizing homogentisate or homogentisic acid? Homogentisate oxidase, absolutely. So first the normal enzyme. So see here, phenylalanine hydroxylase is the normal enzyme, tetrahydrobiopterin is the cofactor. Don't mess this up. So does cystathionine synthase work here in this slide? Does cystathionine synthase work here? Yes or no? Does cystathionine synthase work here? I'm asking you. So what does cystathionine synthase metabolize? What does cystathionine synthase metabolize? Is it a tyrosine or is it homocysteine? What does cystathionine synthase metabolize? Homocysteine. Keep the right enzyme, right cofactor, right step in the right pathway. When I'm talking cystathionine synthase, it's homocysteine. So you understand my point? Also, then you do classic versus non-classic, which we will bring later. But don't forget, tetrahydrobiopterin is not just used by this enzyme. Which are the two enzymes uses this cofactor? Which are the two enzymes use this cofactor? There are two more enzymes that use the same cofactor. Tyrosine hydroxylase to form catecholamines and tryptophan hydroxylase to form serotonin. So this cofactor is common to three enzymes: phenylalanine hydroxylase, tyrosine hydroxylase, and tryptophan hydroxylase. That is why when I'll teach you classic versus non-classic, we have to address this normal. Please know normal to know abnormal. Does that make sense? Normal enzyme, normal cofactor, is it? So look at this slide. Is this cofactor used in other enzymes too? Yes, not just phenylalanine hydroxylase, tyrosine and tryptophan hydroxylase also uses them. This will help you in differentiating classic from non-classic PKU. Folic acid. When you learn folic acid, instead of learning the forms, formyl, methyl, methylene, no, not for Folic acid, just understand it's for use for three syntheses: purine, pyrimidine, and methionine. But then don't stop there. If folic acid is required for methionine synthesis, tell me which other vitamin is also required for methionine synthesis. Apart from folic acid, which other vitamin is required for methionine synthesis? I'm being very specific. Along with folic acid. Which other vitamin is B12, not B6? Not B6. B6 is required for cystathionine synthase, not methionine. Very good. I want you to go there. B6 should not come to your mind. Yes, when I say folic acid, for methionine synthesis, you require folic acid. The other vitamin that should come to your mind is B12. B6 is wrong. So see, that's okay. You still have time. Just don't flip-flop and mix these vitamins. These are very important. Please, this normal is important so I can explain you inborn errors in the end. I'll bring back all of it. So understand, when I'm saying methionine synthesis require folic acid, other vitamin that should come to your mind, now tell me, should be B6 or B12? For methionine synthesis, other vitamins should be B6 or B12? B12. Be very mindful of the vitamin. Take your daily vitamin and don't flip-flop them on the test, please. Take them adequate that you don't flip-flop. Right? I don't want you to memorize the forms. I'm still telling you, as I told you in folic acid in the previous slide, it is used for purine, pyrimidine, and methionine synthesis respectively. You don't need to know the form, just what it forms. Though Dr. Panini has mentioned, but yes, I want to bring to your attention that both methyl tetrahydrofolate and methylcobalamin, tell me, is used for the synthesis of. Both methyl tetrahydrofolate and methylcobalamin is used for the synthesis of. You got to complete the sentence. I want you to keep jogging your brain when I'm doing a recap. It should not be a uniflow, right? Bidirectional flow. So methyl tetrahydrofolate and methylcobalamin is used for the synthesis of. Succinyl-CoA is the right answer. Methyl tetrahydrofolate and methylcobalamin is used for the synthesis of only methionine. Succinyl-CoA is not the right answer. Who is responsible for succinyl-CoA synthesis? Adenosylcobalamin. So you get my point? You understand what I'm saying? Methyl tetrahydrofolate, methylcobalamin is only methionine synthesis, not succinyl-CoA. Right? Are you clear with that? Succinyl-CoA will be adenosylcobalamin. Does that answer your question? Did you correct yourself now? If you're making a mistake? Yes or no? Is there any confusion? Methyl tetrahydrofolate and methylcobalamin is only methionine synthesis, right? Please be specific. Sam is not your next door neighbor, is also involved in synthesis in your body. All you need to do is first, I'm telling you, if you want to do good on inborn errors of metabolism, just do the normal and then which step is being asked. So 1 and 2, right? Each one of them have different enzyme and different cofactor. Similarly, when I asked you methionine synthesis, let's look at this. When I asked you methionine synthesis, both folate and B12 are required for, when I asked you methionine synthesis, somebody said B6. So now you see, do you require B6? Do you see my cursor? Do you require B6 for methionine synthesis? Do you require B6? No. So you will make a mistake when you will do inborn errors of metabolism. Now, this is all you need to do. First, put the right step, right vitamin, right enzyme. Secondly, differentiate. This is very easy to differentiate. First, understand that high homocysteine, is it good for your heart? Is high homocysteine good for your heart? Actually, it has been implicated as a new marker for a cardiac marker, which is homocysteine levels. No, because homocysteine is atherogenic. That's why high homocysteine is not good for your body. You have to metabolize homocysteine. High homocysteine, what history would you see? History of myocardial infarction, because high homocysteine affects small and medium-sized vessels. But you got to understand that homocysteine can be metabolized by two pathways. So now it's very easy to differentiate one versus two. So tell me, if homocysteine is accumulating because of B6 defect or cystathionine synthase defect, what will happen to methionine levels? If homocysteine is accumulating because of B6 or cystathionine synthase defect, what will happen to methionine levels? Sorry, look at my cursor. What will happen to methionine levels, high or low? Why decrease? Is this step, will methionine levels be low? It will increase because B6 because of B6 and cystathionine, when homocysteine will accumulate, it will go into the second pathway. Methionine levels should be high, not low. Where would be methionine level high? When, look at my right side, when it's either folate, B12, or this enzyme deficiency. Then methionine, what did I say? Methionine. Did I say methionine levels high? Sorry. Where would be methionine levels low? When two step is defective. But when one step is defective, actually methionine levels will be high. Does that make sense? So you got to be careful, right enzyme, right vitamin. So, okay, you got confused with this. Basically, I messed up a little bit. So also, so I was asking you if there is any defect in pyridoxine, B6 or cystathionine synthase, apart from homocysteine accumulating, what will happen to methionine levels? This was my question. If you have a B6 or cystathionine synthase defect, apart from homocysteine accumulating, what will happen to methionine levels, high or low? This was my question. So what would you be answer? What would be your answer? High. Very good. Someone said low, so I corrected them. Methionine levels will be low only when these two are defective, whether the methionine synthase enzyme, folate, or B12. Yes, very good. It will be diverted to the other pathway. Yes. So you got to understand that. It's the same pathology. Whenever there is an enzyme defect, substrate accumulate, products are low, and substrate follow alternate pathway, and that becomes high. Does that make sense? This is vomit. Please know that. But again, don't flip-flop these enzymes. So if I ask you, all the vomits, are they glucogenic or ketogenic? All these vomits on the top, are they glucogenic or ketogenic? Are these, they are glucogenic, but you are not memorizing them. You know, if they are converging into succinyl-CoA, TCA minus acetyl-CoA, they will be glucogenic. So please don't memorize this. Once, please, first normal. Now you do. So when I say, one thing I want to bring to your attention, which I forgot, is I don't want to go back, but when you compare homocysteine, have two pathways, right? Homocysteine to be metabolized are by two pathways. It's easy to distinguish whether B6 is defective or folate and B12 is defective. But what about the second pathway? If folate and B12 is defective, what would be high and what would be low? Tell me, when it's homocysteine methionine. If folate and B12 are defective, what would be high and what would be low? If folate and B12 are defective, what will happen to homocysteine? Methionine will be low and homocysteine be high. So then how will you distinguish whether because the finding will be the same, whether it's folate or B12 defect, homocysteine will be high and methionine will be low. So how will you distinguish then? Then you come back to this step. If it is due to B12 deficiency, apart from homocysteine, what else will accumulate? If it is because of B12, not folate. So you got to also distinguish both folate and B12 defect or deficiency will have high homocysteine and low methionine. Then how will you confirm? You will come to this step then. Yes, if it is because of B12 defect, then apart from homocysteine, methylmalonyl-CoA will also increase. Apart from that, you will not know, because you will learn when you will learn vitamins. Because of B12 defect, do you know that all this accumulates in your body and cause neurological signs and symptoms? That's why B12 deficiency, how else you will differentiate? They have neurological signs and symptoms, which is not seen in folic acid deficiency, like tingling, paresthesia, numbness, subacute combined degeneration. So yeah, so when you compare two homocysteine metabolism, it's easy. But what about homocysteine methionine conversion? You have two vitamins there, so you got to understand that. All I'm bringing your attention is how do. You can go back to Dr. Panini's slide, but I'm just telling you how you got to understand these steps. Does that make sense? Right? Just finding common parameters and differentiation. SAM is not your next door neighbor. It's used for synthesis of epinephrine. Now look at this. What are we going to do from now? I explained you what do you need to do for carbon skeleton, their fate. I explained you for inborn errors, first know all the important normal steps, right vitamins, right enzyme. But what are you going to do with this? Don't get lost in this reaction. All you got to do is make a list of amino acid and what specialized product is forming. So is melanin formed from tyrosine or tryptophan? Is melanin formed from tyrosine or tryptophan? Does tyrosine, and what's the defect have you learned? Where you cannot form melanin, total absence of melanin, albinism. Now, once you know albinism is total absence of melanin, does PKU also present with total absence of melanin? Does PKU, because in PKU also tyrosine is low. Does PKU patient present with total absence of melanin? No. Anybody who's saying yes is wrong. No, they do not present as total absence of melanin. They may present as hypopigmentation because tyrosine is low in them. Does that make sense? So see, two things you can learn from this step. Number one, make the list of the amino acid and what do they form. Secondly, you can also understand the inborn errors of metabolism, total absence of melanin, albinism. Thirdly, you can understand, so see, know the normal list, then go clinically also. Where can you have low melanin and hypopigmentation? Patients with PKU. Does that make sense? So make the normal list, but also go clinical. Does that make sense? Here also make a list of it's just you are not memorizing these reactions. You're just making amino acids and their important product list. And this is all about tyrosine. So are catecholamines formed from tyrosine, but are they degraded too? Yes, they have degradation product. Where have you learned clinically these degradation product? Wherever they are increased. So similarly, what are we doing in tyrosine? Tyrosine forming specialized products. Tyrosine forms them, who degrades them? MAO and COMT. Tryptophan, so what does tryptophan forms? Does tryptophan form melanin? Does tryptophan form melanin? No, so the tryptophan has a separate list. So make a separate list and don't flip-flop it. Then do clinical. Is serotonin being taught anywhere clinically? Yes, in depression. In depression, do you want to increase serotonin availability? Absolutely. And carcinoid tumor, too much serotonin, too much 5-HIAA. So first make the right list. I always tell students, if you don't know normal, you don't know abnormal. So first make the list of the amino acid, whatever they are forming. Don't flip-flop that list and then go clinically around that list. Does that make sense? Histamine and GABA are also important amines in your body. This is again the list, glycine, where all you can see glycine. So I have clearly identified, even in my lecture slides, what are the amino acid and what they form. Don't flip-flop them. So does glycine form serotonin? Does glycine form serotonin? No, so don't flip-flop the list and then go clinically where all you have learned them. So this is all which is like summarized in the end. Know the list of amino acid and then what they form, right? Keep doing that from your lecture slides, right? Now let's do inborn errors of metabolism. So are you clear with the carbon skeleton? So there are 3 sections today: carbon skeleton, fate, essential, non-essential, conditionally essential, difference, glucogenic, ketogenic concept, right? Then for inborn error, first make the list. So first identify steps, enzyme, vitamins. For specialized product, just make the list. And if there is any clinical correlation, do that. All of them you should know: homocystinuria, maple syrup, alkaptonuria, albinism. We have done that. How will you identify them? I told you, please first make no, sorry. Please first draw them separate, know the vitamins and the enzyme. Yes, and as I told you, it's easy to distinguish the first pathway defect from the second pathway defect. So how would you differentiate first and second pathway defect? In first pathway defect, what will happen to homocysteine? High or low? If the first pathway is defective or this step is defective, what will happen to homocysteine? High. So now this you got to be very clear. So to metabolize homocysteine, how many vitamins you need? To metabolize homocysteine, how many vitamins you need? 1, 2, or 3? You need 3 vitamins: B6, B12, and folic acid. So know these 3 vitamins and then differentiate. Defect of which vitamin, you would see what level change. So for example, if there's a B6 defect, what will happen to methionine? If B6 is defective or cystathionine synthase is defective, methionine will be high. There would be a common finding. What's common to both 1 metabolism and 2 metabolism defect, as my cursor is, high homocysteine. But what is differentiating both? What is differentiating both the step defect? What is actually differentiating? And you will become methionine levels. If methionine levels are high, is it 1 or second step defect? If methionine levels along with homocysteine are high, is it 1? Or if homocysteine and methionine levels are high, is it 1 or second defect? 1 pathway is defective or second, if both homocysteine and methionine are high. Some people are still saying 2. I'm saying if homocysteine and methionine both are high, is it step 1 defect or step 2? It is step 1 defect, not 2. So anybody who's saying 2 is wrong, right? Do you understand that? I hope you're not confused. Yes?
Do you mind walking through that one more time? Because I'm in the confused population of
So
step
I was,
1, 2, and
yeah,
3.
very good. No, no worries. I was saying 1 and 2, both are metabolizing homocysteine. So if you have a 1 pathway defect or a 2 pathway defect, in both of them, homocysteine will be high. So that's not differentiating. That's common. So what will be differentiating is methionine levels. So that is why I was asking which step defect, 1 or 2, methionine levels will be high along with homocysteine. 1 step or 2 step, in which one of them homocysteine and methionine both will be high? Your question is there, so I'm asking you, 1 step or 2 step?
Would
Both
it be 1 step?
homocysteine. Sorry?
Would it be 1 step then?
Yes, because homocysteine wire now will be diverted to pathway 2. Yes, in 1 step defect. Both
Okay.
homocysteine and methionine will be high. Does that make sense? So there will be one thing common, but there would be one thing differentiating and will be conclusive. That's where I'm bringing your attention to. So this is actually what is on the slide. When this step is defective, both homocysteine and methionine will be high. Does that make sense?
Yes, I think I was only confused because I thought it was going to shuffle to methionine and bring down homocysteine since it's going somewhere else, but it would
No,
still stay
no.
high.
That is very correct. When you are saying this step is defective, homocysteine is accumulating, but is also increasing methionine synthesis. That's all.
Okay.
It's not reducing homocysteine. It's in fact bringing methionine levels also high along with them.
Mm,
So understand that this is accumulation and this is synthesis increased,
okay.
right? No, it's not diverting homocysteine. It's just building up homocysteine as well as methionine, right? Does that make sense? Yes.
Mhm.
Please understand that when one pathway is shutting down, the second is diverted and turned on. I think that's the concept, right? Now, this is also very important concept. Now, I told you 1 and 2 step, you can easily differentiate by methionine levels. But what about if the 2 step was defective? It can be because of folate as well as B12. I told you the difference. You will see methylmalonic acid levels to differentiate whether the 2 step defect is because of folate or B12. Also, please know that not in folic acid deficiency, in B12 deficiency, you see the folate trap. So both folic acid and B12 deficiency, do they present as macrocytic anemia? Do they both present as macrocytic and megaloblastic anemia? Folic acid deficiency and B12 deficiency. Do they both present as folic acid, they both present as macrocytic and megaloblastic anemia. But in folic acid deficiency, macrocytic and megaloblastic is because of low folate in the diet or absorption. But in B12 deficiency, in B12 deficiency, macrocytic and megaloblastic anemia is because of the folate trap. You don't want to see folate trapped. You want to see it free. Why? What does free tetrahydrofolate synthesize in your body? What does free tetrahydrofolate synthesize in your body? There were 3 syntheses. Why do you want this folate to be free? What does free tetrahydrofolate synthesize in your body? There were 3 syntheses. Methionine, not tyrosine, not tyrosine. Folate was not tyrosine, not catecholamines. Where are you all going when it's purine, pyrimidine, and methionine? Folate was purine, pyrimidine, and methionine. Please correct yourself with vitamin where they are required. Do not flip-flop them. Tetrahydrofolate, you're not thinking tyrosine. Sorry. Tetrahydrofolate, it's purine, pyrimidine, and methionine. Great, right? But I told you when you want to distinguish folate and B12, it is not easy because in both of them, homocysteine would be high, methionine would be low. So where would you go then? To the other steps. So understand how you have to how you have a common finding in this defect, but then you have to distinguish whether it's because of folate or B12. So if methionine synthesis is defective because of cobalamin, what else will increase in your body? If methionine synthesis is defective because of cobalamin, what else will increase in your body? If methionine synthesis, methylmalonic acid, right? Methylmalonic acid. But if methionine synthesis is defective because of folate, will you see high methylmalonic acid? If methionine synthesis because of low folate, will you see methylmalonic acid? No. So you got to differentiate, absolutely. So you got to differentiate that they are all 3 vitamins are required, B6, B12, folate for homocysteine metabolism. Somebody's asking me why. So if you have a folate defect, will methionine be low? If you have a folate defect, will methionine be low? But if you have a folate defect, will methylmalonyl-CoA accumulate? If you have a folate defect, will you have high methylmalonyl-CoA? Somebody's saying yes. Why? Does it require folate? If you have a folate defect, will you accumulate methylmalonyl-CoA? No, no, please pay attention on the step, vitamin, enzyme. If you don't flip-flop them, you will understand exactly what is accumulating, what is depleting. So in folate deficiency, MMA will not accumulate. Does that make sense? In folate deficiency, homocysteine will accumulate. That's what I was trying to distinguish. Does that make sense now? But I think it's too early. It's too early. You got to write down the step. I'm just bringing your attention, right? These are branch chain amino acid. They need a dehydrogenase. It is thymine dependent. So what is leucine and lysine? Usually students are confused between these 3 versus leucine and lysine. What are leucine and lysine? What are the ketogenic? But this is leucine, isoleucine, valine. They are different, right? So branch chain amino acid, by dehydrogenase, they are catabolized. They are used by skeletal muscle for energy needs, thymine dependent. Defect leads to maple syrup urine disease. So why am I bringing this to your attention is when I talk about maple syrup urine disease, am I talking about phenylalanine defect? When I'm talking about maple syrup urine disease, is it phenylalanine defect? So you got to be clearly identifying. Phenylalanine defects means classic and non-classic. When you say tyrosine defect, it's alkaptonuria, albinism, and tyrosinemia type 1. So you have to identify the correct amino acid with the correct defect. Does that make sense? So when I say maple syrup urine disease, it's not phenylalanine. Does that make sense? Right? Classic and non-classic. This is this is now I'm going to just differentiate and tell you how normal is so important. So when you compare classic with non-classic, remember classic always means usually. When they say classic, it is either enzyme or more common. Non-classic is usually coenzyme or cofactor, less common. Classic is usually enzyme and more severe. Non-classic is cofactor and mild, but both can present as a common finding. How will you differentiate? Now tell me, classic PKU is severe, so it will have, and what does, also you should be very familiar with the predominant presentation. So what is the predominant presentation of PKU patient? Central nervous system, joints, uh, uh, liver. What is the primary presentation of a PKU patient? What system is affected? Central nervous system. So by looking at the question stem, if you see CNS changes, go towards hyperphenylalaninemia or PKU, right? If there are arthritis changes or arthritis, go towards alkaptonuria. So keep an eye on the primary system affected too. Secondly, non-classic. Now, how will you differentiate classic from non-classic? Do you know that tetrahydrobiopterin? Yeah, excess phenylalanine urine. So tetrahydrobiopterin is used by 3 enzymes: phenylalanine hydroxylase, tyrosine hydroxylase, and tryptophan hydroxylase. So how will you identify this patient is non-classic? If you just restrict phenylalanine in this patient and send them home, will it be okay? Will they be okay? If you just restrict phenyl, no, because because tetrahydrobiopterin is also required by tyrosine hydroxylase and tryptophan hydroxylase. They will come back with neurological signs and symptoms. So you have to supplement neurotransmitter precursor in cofactor defect. You will not do that in classic or enzyme deficiency. So you got to clearly know that when it's non-classic, enzyme is normal. When it's classic, cofactor is normal. Does that make sense? Yes. When it's enzyme deficiency, cofactor is normal. When it's cofactor defect, enzyme is normal. You have to assume that, right? Does that make sense? And then talk around the step. What is PKU? I told you, substrate accumulates, the same thing. Product is depleted. Substrate accumulation follow alternate pathway. That's why they have a musty or a mousy odor. CNS presentation, yes, PKU. What about non-classic? I told you how is non-classic different from classic? Is the classic, first of all, non-classic will be mild. And how would you know they are non-classic? You can measure the cofactor. So in non-classic hyperphenylalemia, cofactor will be normal or low. In non-classic form, cofactor will be abnormal. In non-classic form, what will be the enzyme? Will enzyme be normal? In non-classic form, will enzyme be normal? Yes, enzyme will not be low. Enzyme will be normal because non-classic is not an enzyme defect. So enzyme will be normal. Don't say it will be low, right? So they are specifically classified. Don't mix and mess them up, right? Tyrosine, I will clearly tell you, please stop phenylalanine metabolism from phenylalanine to tyrosine. Don't carry over. Okay. So this is only phenylalanine metabolism. Here, tyrosine metabolism starts. But as I told you, when you do cofactor defect, this cofactor is also required by other 2 enzymes. So when there is cofactor defect, definitely you have to supplement neurotransmitter precursor. Otherwise, these patients will come back to you if you only restrict phenylalanine. So cofactor defect are definitely different from enzyme defect because cofactors are used by 3 enzymes: phenylalanine hydroxylase, tyrosine hydroxylase, and tryptophan hydroxylase. So do you differentiate classic from non-classic? Absolutely, do that for me. They are not the same presentation. Classic is severe. I told you the musty odor, CNS involvement. Non-classic, how they are different. This cofactor is also used by other enzymes. So you have to supplement those neurotransmitter precursor when it's a cofactor defect, apart from restricting phenylalanine. Right? Does that make sense? So understand classic versus non-classic. Clearly identify that. Also tyrosine, tryptophan, glycine, everywhere. Please make the list of what they form. Don't flip-flop the list. And did we do 2 pathways? So tell me what would be tyrosine defect? What would be tyrosine defect that you know? Just give me tyrosine defect. For non-classic, for non-classic, the cofactor is the issue. Either cofactor is not synthesized, so there is a synthesis defect, or recycling. It could be both. It could be tetrahydrobiopterin synthesis or dihydrobiopterin reductase, which is recycling. Both could be defective, either one of them. I'm just answering question 2. So when you say tyrosine, you should know 3 metabolic pathways. 1, albinism. Number 2, alkaptonuria. Number 3, tyrosinemia type 1. Very good. Don't flip-flop them. Don't flip-flop the disorder and what amino acids they are related to. Right? Also understand which is alkaptonuria. This one, or well, I have the on the slide, so it's silly to ask it. But which one is alkaptonuria? The top one or the bottom one? Alkaptonuria is top or bottom? The top one, naturally. So also understand wherever there is a defect. So in top or bottom, where will succinyl acetone accumulate? Alkaptonuria or tyrosinemia type 1? Where will succinyl acetone accumulate? Tyrosinemia type 1. Yes. So top one was alkaptonuria. Now again, if there are CNS changes, will you pick alkaptonuria? If the history shows CNS changes, do you want to pick alkaptonuria? No, you want to pick PKU, right? But if there are joint changes, arthritis, these alkaptone bodies, then what do you want to pick? If there are joint changes, darkening of joints, alkaptonuria. What about total absence of melanin? Melanoma history of melanoma, total absence of melanin. And history, they are prone to cancer, skin cancers, melanoma, albinism. They all have a characteristic history. Please don't flip-flop it. All have a characteristic history. If you identify them at the right place, inborn errors are good. This is what I was telling you. Succinyl acetone will not accumulate in this one, alkaptonuria. It will accumulate in tyrosinemia type 1. Alkaptonuria is here. Tyrosinemia type 1 is here. Right? Does that make sense? So where is the defect is important, right enzyme, right vitamin, and this is the same, right? Right vitamin, right defect, where methylmalonyl-CoA, okay. In this case, which defect, 1 or 2, will lead to metabolic acidosis because of propionic acid? 1 or 2, in which metabolic acidosis will be due to accumulation of propionic acid? 1 or 2? 1. In 2, metabolic acidosis is because of accumulation of methylmalonic acid. But both may show metabolic acidosis. So there will be a common finding, but there is a differentiation. Identify the right enzyme, right step, and right step defect. Does that make sense? You will never go wrong, right? Does that make sense? Here also, I want to bring your attention that, sorry, give me a second, that when you're confused between whether folate or B12 is responsible for methionine, defect is responsible for methionine synthesis, you could also assess levels of methylmalonyl-CoA. So these could could differentiate whether methionine synthesis is because of folate defect or B12 defect. Does that make sense? That's where Dr. Panini has brought up MMA1 versus MMA2. So tell me, MMA2 is because of methylcobalamin as well as adenosylcobalamin defect. So what will be high in MMA2 patients? It's because of methylcobalamin as well as adenosylcobalamin. What will be high in MMA2 patients? It's methylmalonyl-CoA and homocysteine both. Both will be high. Yes, both will be high. For that, I told you, you should know normal to know abnormal. Unless you know that B12 is required for metabolizing both homocysteine and MMA, you will not understand that B12 defect will build up both homocysteine and methylmalonic acid, especially which form? Adenosylcobalamin. Does that make sense? Oh, this is my last slide, so maybe I'm messing up again. So what I'm telling you, if you don't know the normal, that methylcobalamin is used for metabolizing homocysteine and adenosylcobalamin is used for metabolizing MMA. So you will not understand that MMA2, where both forms are low, adenosyl and methyl, what will accumulate? That's why, because of low methylcobalamin, what will accumulate? Homocysteine. Because of low adenosylcobalamin, what will accumulate? MMA. Did I correct that now? Or no? This is my last slide. Did I correct myself now? Last time before you all leave, I'm saying that you should, unless you know that methylcobalamin is used to metabolize homocysteine and adenosylcobalamin is used to metabolize MMA normally in your body, you will not understand that methylcobalamin defect will lead to high homocysteine and adenosylcobalamin defect will lead to high MMA. Does that make sense now?